information. We will also provide you with the slides from the webinar, and you'll receive a follow-up email that has the links to all of those things. So don't worry if you miss anything, you'll be able to access it later. And if you experience technical issues, you can always watch the recording at a later time. We'll also be taking questions at the very end of the presentation. So throughout the session, you can go ahead and put your questions in the Q&A box or in the chat box, and we will address them all at the end. But if you think of anything, go ahead and put it in there during the presentation. So in today's webinar, we will be discussing the topic of growth hormones for pediatric patients who have Turner syndrome. And this is a very important topic for our community because it is the most common physical condition related to Turner syndrome. And we always are asked so many questions about growth hormones. So we thought this would be a great way to give parents and caregivers the chance to learn and ask questions and hopefully clear up some questions that might exist around the topic. And so we want to thank and introduce our presenter, Dr. Gwyn Roper. Dr. Roper is both a physician and a woman who has Turner syndrome. She has practiced pediatric endocrinology since the year 2000, and she loves interacting with other girls and women who have Turner syndrome. She did her pediatric residency at the Medical College of Virginia in Richmond and her pediatric endocrinology fellowship at the University of North Carolina at Chapel Hill. And she has been a pediatric endocrinologist in Knoxville, Tennessee, Gray, Tennessee, and most recently in Greenville, South Carolina. So that is our presenter. Thank you so much for being here with us tonight. And we will hand it over to you, Dr. Roper.
Thank you, and good evening. It is my pleasure to speak with you tonight. And just to give you a little more information about one of the main treatments that is gets presented after your diagnosis of Turner syndrome. And just allay maybe some fears and answer some questions about growth hormone treatment. So I'm going to right now pull up, try to pull up my presentation here. Let's see, I think. All right. I think it is pulled up. Can everybody?
Yes, we can see it.
Okay, good. I wanted to make sure.
Of course.
So basically, growth hormone is a presentation, and what I'm trying to do is trying to see if I can go through it with you, but for some reason, it's not letting me do that.
It's not letting you move to the next slide?
No. And
if you go to the bottom left corner, you see two arrows, right and left. Maybe if you click those, it'll let you go to the next slide.
Bottom corner. Let's see. I'm sorry about this. Let's see.
That's okay. We looked at it before and it was working just fine. So
I know. That's
these
what
things happen.
Corner. Let's see. I know. All right. I'm trying to see if resume slideshow. Let's see. All right. So do you see it moving now?
Yes, we see it.
Okay. All right. Well, good. Now we're all set. Anyway, basically, growth is a major issue once you have been diagnosed or once a girl has been diagnosed with Turner syndrome. And this is one of my favorite pictures of a little girl trying to see how tall she is. Short stature or being small is seen in over 90% of girls with Turner syndrome. So it's a big issue that you talk to your pediatric endocrinologist about. This is a picture of me at about 2.5 years of age when I was diagnosed with Turner syndrome. I had a very astute pediatrician who happened to notice that I was falling off the growth curve, and I had just read an article on Turner syndrome and got me the treatment that I needed. So just to give you a little bit of history about growth hormone. Growth hormone in the body is a protein made in the major control center in the brain called the pituitary gland. And growth hormone not only controls growth, but it has a lot of other functions and affects metabolism, bone, heart. So there are other needs for growth hormone. And actually, believe it or not, adults make growth hormone even at minimal amounts for heart reasons, bone reasons. So it's a big deal and a big need. And just to kind of set the record straight, girls with Turner syndrome are not growth hormone deficient. It's almost a growth hormone resistance, but we do know that growth hormone does work. And I do have a little personal stake in this presentation. I was placed on growth hormone for 9 years. This was actually before growth hormone was FDA approved as a treatment in Turner syndrome. So I was on a lot of the pilot programs. And now, thank goodness, we know a lot more about dosing and a lot more about easier ways to administer growth hormone. Growth hormone as a treatment has been around since the 1920s. It was first used to replace growth hormone that was missing in pituitary disorders or in medical issues that compromise the pituitary gland's ability to make growth hormone. It was initially obtained from the brain tissue or pituitary tissue of cadavers. In 1985, there was a synthetic way that was discovered to make growth hormone. So it did not have to be obtained from cadavers. In 1996, it was FDA approved for the treatment in Turner syndrome. Now, in Turner syndrome, why is growth hormone important? First of all, we touched on growth and short stature. That's seen in over 90%. So it's a big deal. But again, there are other reasons. Girls with Turner syndrome tend to fall off the growth curve by 3 to 4 years of age. Actually, about 75% do. So obviously, growth hormone is needed for growth and achievement of final adult height. Growth hormone is also needed for building your bone bank. So getting an appropriate bone mineral density, especially in combination with hormonal replacement or estrogen that you are making spontaneously. Some girls do start out making estrogen on their own. So the combination of growth hormone and estrogen builds your bone bank and prevents low bone mineral density or osteoporosis and fractures, which obviously we don't want. Growth hormone also helps with heart health, also specifically lowering total cholesterol and your what we call bad cholesterol or LDL. So it's important for heart health. I wanted to show you, this next slide is a picture of a growth chart, Turner syndrome growth chart, actually. The pink lines are where a girl with Turner syndrome can be expected to be. The 50th percentile, or where you say 50, or C50 on the pink, is where the average adult height or average adult female will end up. And that is 4'8" without any treatment. The average adult female will be 4'8". The red is just kind of a comparison of the normal growth chart and normal growth and normal heights. Now, when do you start growth hormone? When should the conversation of growth hormone be brought up in Turner syndrome? I have brought it up pretty much just from the very beginning, stating this is most likely going to be a need and giving just a little bit of a brief discussion of growth hormone and answering brief questions and kind of giving an overview of when we might consider starting the treatment. Unfortunately, a lot of girls at diagnosis have already fallen way below the growth curve and are needed growth hormone yesterday, basically. So that's unfortunately the large amount of patients we see. But you can start growth hormone. We've started it as soon as 9 months of age. So the recommendation as of the new clinical guidelines for the treatment of Turner syndrome that was published in 2017 is to start growth hormone by 4 to 6 years of age, or at least by preteen or 12 to 13 years of age for those exhibiting growth failure or for extreme short stature. And again, typically this is about 75% or more. How do you take growth hormone? A lot of people hope that it's a pill or something that's easy to take. Unfortunately, because growth hormone is a protein, it does have to be taken by injection, which is a very scary thing for especially parents to think about, and especially when they are told that they're going to have to give this shot to their child, to their little girl, on a nightly basis. That's a scary thing. So I'm going to kind of go through basically what you can expect when the conversation of growth hormone comes around as far as treatment. Growth hormone is an injection that it is given just under the skin. It actually used to be in the muscle, much like the flu shot. So we come a long way as far as pain. It is just a little prick. And the person who actually prescribes the growth hormone will be your daughter's pediatric endocrinologist. And hopefully your pediatric endocrinologist communicates very closely with your pediatrician, who was most likely the one that sent you to the endocrinologist. But your pediatric endocrinologist will start this discussion and explain growth hormone to you. They'll be your main person. This is a picture of what a growth hormone device actually looks like. It's a pen device. It's called a pen device. Looks like a pen, and it has a little dialer at the end where you dial up the dose. When you uncap this little cap here, you attach a little needle, and there are typically two sizes of the needle, a 29 gauge and a 32 gauge. The larger size of the gauge, the smaller the needle. So they're very, very, very tiny, as you can see, much like the diabetic needles. Where do you give growth hormone shots? Actually, just under the skin, you can use, this diagram shows you, you can use just the backs of the arms where you can pinch up a little skin, just on the buttocks, on the sides of the legs and kind of the fronts of the legs. And you also can use the sides of the abdomen, believe it or not, for growth hormone shots. These ones, these sites in the red are the most common, and the sites that that kids most often gravitate towards. I've had kids as young as 6 learn and love to give their own injections. Of course, the first one is a very scary one. But again, it's something that you become used to, kind of like brushing your teeth. It becomes a nighttime routine. I've said basically that growth hormone, every night is given at night. I've kind of been saying that. And a question might come up in your mind, why give it at night? Does the timing really matter? Growth hormone, physiologically, or as it normally should, is given impulses most often during sleep, actually in the 4th stage of sleep. So sleeping is very important, getting a good night's sleep. But why growth hormone is given at night is to make it, or is to give it in a way that's as close to the body's way as possible, to kind of mimic the body's way. So it's something that kind of can get part of a bedtime routine, brush your teeth, do a bedtime story, whatever you need to do, and then get the shot, and it's bedtime. So once you start growth hormone, and once you get over that big hurdle of your first injection and learning all about growth hormone, what are the initial things to expect? The first thing that, or first two things actually, that I am told at a follow-up visit after starting growth hormone for Turner syndrome girls are, number one, wow, she's eating me out of house and home. So a big appetite, which is a good thing. And also an increase in shoe size. You know, wow, I've had to go buy her new shoes. And usually this occurs in maybe the first 6 weeks of starting growth hormone. You typically see a big increase of growth within the first 3 months. The normal growth rate of a child is 2 to 2.5 inches a year. After starting growth hormone, that can almost double as far as 5 inches a year for the first year, and then taper off to just a normal growth rate. And basically bring your daughter back onto the growth chart. Also, another thing that's noticed is increase in lean muscle mass. So less kind of body fat, less chubby areas, so to speak, and kind of a leaner look, which is great. And that's something that the girls enjoy. So how do you gauge a response to growth hormone? Who's going to respond the best as far as girls with Turner syndrome? The taller that your height is before you start, the taller your final predicted adult height is, and the younger you are before you start growth hormone, or the younger the younger you are when you start growth hormone, you're going to see the best effect. Also, the longer you are on therapy, you're going to see the maximum effect of growth hormone. Basically, what are the risks? And that's one of the first things that comes to mind when you're thinking about a medication. You know, what do I look for as far as side effects? How serious are those side effects? I can reassure you and tell you that side effects from growth hormone in Turner syndrome girls are seen in less than 1%. In my 20 years practicing, I would say I may be able to count on one hand, maybe, the amount of kids that had complications with growth hormone. Actually, maybe 2 of them had Turner syndrome. So you can say it's very rare, but it's important to be educated in the side effects. The first thing that your daughter might complain about is a headache. This is caused by increased pressure in the brain. The big fancy word for it, I want you to know because you'll see it on the internet, your doctor may say it, is pseudotumor cerebri. It actually means fake tumor. So a headache as if there's, you know, a tumor in the brain, basically a bad headache. This headache often starts soon after starting growth hormone. It's often difficult to relieve or to go away. If this should happen, you should just contact your pediatric endocrinologist immediately and notify them of the headaches. What your endocrinologist will do is to ask you to stop the growth hormone and to get your daughter a good eye exam. As soon as the eye exam is done, if everything's fine, growth hormone can be restarted without any consequence. If there is increased pressure, the ophthalmologist is the one that can kind of, through a good eye exam, see if there's increased pressure in the brain. If there is, it typically resolves within about 3 to 4 months after growth hormone is stopped. And most girls do fine restarting growth hormone. And I say most girls do fine. The ones that don't are just the ones that have decided they don't want to fool with it anymore and just don't restart growth hormone. So pretty much everybody that restarts it does well. But that's the biggie, and that's a biggie that you will see online and that your doctor may tell you about. Other things that to think about are a slipped hip bone or something called slipped capital femoral epiphysis, or what we call SCFE, SCFE. If this should happen, can be corrected orthopedically. If there's scoliosis, this can worsen with growth hormone. And do understand that if there is scoliosis, just as if it can worsen with a big growth spurt, in a normal growing girl, this can happen. So anytime you get just a big growth spurt, any scoliosis can either possibly develop, particularly if there's a family history, or worsen. And so if this is if this happens to occur, you can discuss it with your pediatric endocrinologist. They will refer you to an orthopedist who can watch you closely. And typically, no issues that I've ever found that require the child actually to come off of growth hormone. So that is good news. Another thing, particularly if there's a strong family history of diabetes, is the development of glucose intolerance, or kind of a pre-diabetes state. I have seen this once. And the good thing is that all of these that I've mentioned, all of these side effects stop after the discontinuation of growth hormone. So once you stop growth hormone, these go away. So that's a good thing. But just bearing those things in mind, basically, the overall benefits of growth hormone should be becoming clear. Not only the importance of height, and this might not be important for some girls. I've had some parents say, hey, you know what, she really doesn't care, it's not life-threatening, so what? And that's a good point to consider. But also do remember that growth hormone is important for bone mineral density, for prevention of osteoporosis. It is important for heart health, and being taller, being as tall as you can be. And with growth hormone today, girls with Turner syndrome can be 5 feet and over. Again, bearing in mind that the average untreated woman with Turner syndrome can be 4'8". That is great news. But this can help self-esteem, and also help in everyday life functions, like going to the grocery store and reaching things on high shelves, or driving, dressing age appropriately. So every even quarter of an inch is important. So your pediatric endocrinologist, once growth hormone is discussed and you agree to start with growth hormone, they will get it started with your insurance, and they will set up training. You won't be on your own. You will come back into the office, and they will set up what's called a training visit, and give your first injection in the doctor's office. So that is very reassuring, and something that I enjoy, because we're all kind of in it together for the first injection. And then you can have your questions that may come up right as you're doing the actual thing answered. When should growth hormone be stopped? That's actually a question that we should address. Yes, you've started growth hormone, you're getting great growth. When do you stop it? Well, basically, your pediatric endocrinologist will do what's called a bone age, or an x-ray of your daughter's left hand. That shows whether the bone plates, or what we call epiphyses, are still open or not. And bone plates close at a bone age of about 15 and a half. So when these little lines, it'll just look like just filled in fingers, but with no horizontal lines at all. All the bone plates will be closed. When this happens, your pediatric endocrinologist will say, okay, we've gotten all the growth that needs to be achieved with growth hormone. So it's time to stop. And basically, it was when I was taking growth hormone, do growth hormone, grow, and then once the bone's closed, start hormonal replacement. But as I said before, now, and especially with starting growth hormone so early, girls can start hormonal replacement at a more physiologic age, an age closer to their peers, like around 12 to 13, and they can get their growth spurt and have a growth velocity that's more in line with their peers, and so they don't feel as different. And that's the one great advantage that has happened with more knowledge about growth hormone dosing. How much will growth hormone cost? That's another big issue. Growth hormone is FDA approved, again, for Turner syndrome. So basically, there really isn't, if you have private insurance, they should not deny growth hormone for the indication of Turner syndrome at all. And if they do, your pediatric endocrinologist will go to bat for you. Your growth hormone will be covered dependent on your copay per your individual plan. So whatever your plan states that you pay a copay for injectables will be what you will pay. Some people pay about $1,000 a year. It can be as expensive as $5,000 a year if it is not covered by insurance. And that is if it is not covered. And once you initially see these figures, it can, startle anybody, obviously. How can I do this? Well, there are several reimbursement plans that your pediatric endocrinologist can make you aware of. Each insurance company chooses a growth hormone company to partner with. There are several major ones: Norditropin, Genotropin, Omnitrope. Growth hormone is manufactured in all of these companies the same way. It's the same molecule. They have just been given the right to manufacture and give it a name that they've decided upon. And insurance companies choose which growth hormone company they want to partner with and they want to deal with. So your insurance company will dictate which growth hormone company you deal with and which pen device you have. And someone from that company will contact you, or should be contacting you, within about 2 weeks from when your pediatric endocrinologist puts everything into the insurance application for growth hormone, to tell you about reimbursement programs, to go over your financial situation, to see how you can be helped. So it is typically a very proactive thing, but you are your daughter's best advocate. So the only dumb question is when you don't ask. Please be sure and just ask for any reimbursement possibilities. There is a growth hormone that is only given by the old vial and syringe for those in the situation, should it happen, which it has never happened to me, under the indication of Turner syndrome, but should an insurance company flat out deny it. And they also have reimbursement plans and can help you with that. So there are several ways to get around the cost. I wanted to throw up this important reference. This is basically where all of this new information that as physicians we have gotten from the clinical practice guidelines for Turner syndrome that was published in 2017. So I wanted to throw that out there. I believe you can have access to this on the Turner Syndrome Foundation website, because I've been on that website. So it's a very useful article. I hope that, I'm sure you may have some other questions. I hope I've kind of allayed some fears and answered some of the questions, but I would be happy to take any other questions at this time.
Okay. Thank you so much, Dr. Roper, for sharing all that information, very extensive, and this was really great I learned a lot too, so this is really helpful to me, and hopefully it was helpful to some of our attendees as well. So I don't see any questions yet, but if there are any questions, please put them in the chat box. If I'm missing your question, I apologize, but let me double check all the places. So yes, if you do have any questions right now, oh, here we have a question. What is your experience with girls with mosaic Turner syndrome with growth hormone?
Oh, mosaic girls with a mosaic karyotype do benefit from growth hormone, just like true Turner girls or those that are just 45X. Absolutely, it is effective in the mosaics as well. And I myself am a mosaic, so that is from personal experience too.
Great, thank you. Let's mark that question answered. If there's any other questions, please go ahead. Okay. Any thoughts about introducing estrogen and how to do that with
Okay, let me make sure I understand the question. Was it when to introduce estrogen? Is that the question?
So I think she's more referring to like questions about the timing of introducing estrogen, if I'm thinking correctly, like having estrogen and growth at the same time, growth hormone at the same time, and things like that.
Yes, maybe when to start the discussion too. Yeah. I start estrogen therapy at an extremely low dose, somewhere between 12 and 13 years of age. Basically, we are now, just because of what we know about estrogen dosing, we can start estrogen, and it's not an injection, thank goodness. One of the treatments, it's not a shot, it is oral. But I've started even with patches, which is the best way to give estrogen. It doesn't go through the liver on the first pass, so that patches are actually best and the most physiologic. But I have started like a quarter of a patch at nighttime only, just to kind of mimic the pulses in puberty that kind of start puberty, if that makes sense. So but somewhere between 12 and 13, that discussion starts with the parents and the girl. And we kind of see how she feels. And we kind of let puberty go over a course of at least 2 years, somewhere between 2 and 3. We kind of do it just, like I said, just as if it would happen physiologically.
Great. So I'm going to add a follow-up question to that. So what if a girl was diagnosed later and so she started growth hormone much later? How would that impact the introduction of estrogen?
Okay, that's a great question. But I didn't start growth hormone until I was 9. If in today's world, if things have been done, correctly, or how we know how to do it, even though growth hormone was started later, the discussion still would happen between 12 and 13 years of age. And what I gauge it on, I'm saying 12 to 13 years of age, but also I look at the bone age as well. That's that left hand x-ray. So I'll get an x-ray, and if it's somewhere between 12 and 13, I'll say, we're good to go. We need to start some estrogen, just even at a low dose with that growth hormone, just to preserve that bone bank.
Okay, thank you. So estrogen therapy is like a whole other topic. So we could do a whole other webinar, so we won't dive too deeply in it, but it definitely relates to growth with regards to these questions. So if anyone's interested in a webinar about estrogen therapy, whether for pediatric patients or adults, let us know so that we can definitely plan that in the future. So, and we do have a lot of questions. We will take all of the questions. We have a lot of time. So just be patient. If we don't get to yours first, we will definitely answer it. So I'm just going to try to go in the order that we received them. So the next question I have is someone that says, hi, I'm Cassiano, father of Helena from Brazil. Helena is mosaic and we started growth hormone at 1 year, 3 months. Is it too early, and what could be our growth expectations?
That is absolutely not too early. And your expectation would be that she would reach a height of 5 feet or above. And actually, Um, a final predicted adult height normally for a girl is dad's height plus mom's height, and then you take the average. And that's what we call the midparental height, or MPH, or predicted final adult height. So your pediatric endocrinologist has that, I'm sure, somewhere, that information. So whatever her final predicted adult height is, I am almost positive if she started so early, she's going to get there.
Awesome. That's so encouraging. Okay, so let me see the next question. How has the recommendations for growth hormone changed in the past 10 years? This person, Haley, says, I'm a 27-year-old woman with Turner syndrome and used growth hormone for about 3 to 4 years, beginning at 10 and a half years old, so about a decade ago. So she's just kind of wondering what's different now than when she had it.
Oh, absolutely, absolutely. When I took growth hormone, and when I started at 9 years of age, it was in the 80s, early 80s. So we're from 81. And basically it was, as I said before, just kind of grow, get all the growth you can, take growth hormone until those bones close, and then start the discussion of estrogen, which actually gives you just a last little bump of height. That was basically what was done years ago. Now we know that the earlier we start growth hormone, that you don't even necessarily need to see the girl with Turner syndrome fall greatly off the growth chart. You know, once it's seen that this can help, even before she falls off the growth chart, you can start growth hormone. Because obviously there are other important factors. That is something that was not done about 10 years ago. That's something that's very different. Another thing is that, well, let's see, 10 years ago would be, well, I would say in 96, when this was approved, it was still in the muscle. But then around that time, maybe 98, 99, 2000 was when the subcutaneous, or just under the skin, injection started. So it was no longer in the muscle. Now that is something that has definitely changed, if that makes sense. I hope I've answered her question.
Yeah, and if anyone asks a question and we don't quite answer it, feel free to add a follow-up question as well. But thank you for that that response. So we'll just keep moving through the questions. Someone asks, what about, we might have already answered this, what about when your daughter is showing signs of puberty? I would assume they're saying while taking growth hormones. So I think we kind of touched on that. If you want to add something, go ahead.
Look, I was just gonna say about 25% of girls with Turner syndrome can have some spontaneous signs of puberty. So really, either way, you know, that's just something that you can discuss with your pediatric endocrinologist, as far as where's the bone age, you know, where are the bone plates, where are we on growth, and where should we go from there. So that is something, that's a great question to kind of discuss with the peds endo.
Okay, great. So someone asked, if Turner syndrome was not diagnosed during childhood, is there any benefit to an adult woman who has Turner syndrome for taking growth hormone, or is it too late?
That is a great question. There is no benefit that we know of in medical literature of an adult woman whose bone plates have closed, whose epiphyses have closed, of taking growth hormone, unfortunately. And I have seen my share that I haven't wanted to see of girls, unfortunately, that have passed the time that they could benefit from growth hormone. And that's a hard discussion to have. Say, well, we can't do anything about your height now. But as far as paying attention to your heart health and bone mineral density, you can do estrogen therapy and make sure you have enough vitamin D, make sure you get your DEXA scan. So those are things to talk to your physician about.
Great. So let me read you the next question. So with mosaic Turners and Y chromosome material, if ovaries are removed prior to growth hormones, would removing the ovaries risk having to start the growth hormones early?
Would remove, okay, so.
I can read it again if you would like, but.
No, I think, let me make sure I understand it correctly. I think, so would removing the ovaries make you have to start growth hormone earlier?
Yes, that's the question.
That's what no, that has no impact actually on when to start growth hormone. It's actually just looking at the growth chart and seeing where the girl is and, where she's falling off. So that, and I'm so glad to know that the ovaries have been removed because there's a big risk there. So that's a good thing, but no, it doesn't impact the time growth hormone.
Thank you. So we'll go ahead to the next question. Thank you all for asking such great questions and being
These
so engaged.
These are great.
Yes. So thank you all for being here, and we'll just keep going through the questions. So someone asked, you mentioned conditions such as diabetes and scoliosis that happen after the start of growth hormone that go away after it stopped. So this person's daughter has Hashimoto's thyroid disorder, and it started once they started growth hormone. And would that go away after they stop growth hormone as well?
Well, that's a good question. Actually, Hashimoto's thyroiditis, or an underactive thyroid, has no relation to growth hormone. That's not one of the side effects. So there is no relation, and that is a good question. But thank goodness there's no relation there, except to say that your pediatric endocrinologist will have to make sure that your daughter's thyroid tests are normal and she's on the right dose, because thyroid hormone works with that growth hormone actually as well for growth. So he or she will want to make sure that your daughter's levels are normal.
Great, thank you. And just to let you all know, we already have planned our webinar for next month, and it's going to be talking about different autoimmune diseases and their prevalence in girls who have Turner syndrome and things like that. So you feel free to ask your questions here too, but I'll just tell you the date and we'll get back to the questions. But just so that you know, next month on September 14th at 8 p.m., we will be having a conversation about autoimmune. So definitely join us for that if that's something else you're interested in. So then someone asked, her daughter Cora started a quarter patch of estradiol about a year ago. She's 11. As of now, she is told that her growth hormone may stop around 13, but you mentioned around 15 or so. So should we expect her to experience menses?
Okay. I think there may be a couple of questions there. So stopping the growth hormone has to do only with the actual bone age, not age in calendar years or chronological age. So I don't know what her bone age is, but that is something to ask her pediatric endocrinologist. Growth hormone actually shouldn't be or is not recommended to be stopped until the bone age is 15 or 15 and a half. So if she's 13 and her bone age for some reason is 15 and a half, then that may be the reason why your pediatric endocrinologist is asking you to stop. Why, that brings me to another question. Why stop growth hormone if the bone plates have closed? What's the big deal about that? I've kind of said that several times. Basically, if there is nowhere to go, if the bone plates have closed and you take growth hormone, you just get coarsened facial features, you get funny bone formations, because there's nowhere for that growth for those bones to grow other than kind of grow out, if that makes sense. You may remember Andre the Giant from The Princess Bride. I don't know if anybody remembers that, but he had a condition where he made too much growth hormone, and that kind of explains his, coarse jaw, his kind of hard facial features, but all that to say, it's the bone age that really determines when you stop growth hormone.
Great. Yeah. And that is a great reminder that there are guidelines and things like that, but everything is so individual and everyone's experience is different. So you should definitely, talk to your trusted healthcare provider about that. But again, these are really good pieces of information to know just generally. And so that's very helpful. And she did also ask, should we expect her to
Yes,
experience menses? So
I just realized that.
dive into that just a little.
Yes, yes. Basically, your daughter can expect her first period about 2 to 2.5 years from when you first see breast buds. So basically, it's going to be kind of like a physiologic thing. So once you start seeing breast buds, and your pediatric endocrinologist will take a look, if not every visit, every other visit. It typically takes about 2.5 years for things to fully develop and then to have your first period with estrogen replacement. When you do it, I don't want to say artificially, but if you do it, not like the body, we usually at least like to do it about 2 to 2.5 years.
Okay.
So I don't
Thank
think
you.
close now, it doesn't sound much.
Okay, thank you. So someone asked, are there any resources to go to when having this talk with my child? And before you answer that, I just want to tell you about a resource that we do have at the Turner Syndrome Foundation. You may or may not have heard of Tina Talks Turners, and it's a little video, and we also have a companion book in which Tina is just a girl who finds out about her Turner Syndrome diagnosis, and she starts growth hormone, and it just kind of, the video is great, I think, because she talks about her experience with it and just how normal it is now in her nightly routine, like you were talking about. She takes her shots and things like that, and it'll help her grow. So that's a really great video, I think, to show your child. And then there's also a book to help her like journal about her experience with growth hormone and just kind of reflect on what she's experiencing. But if you know of any other resources, Dr. Roper, to be helpful to parents, please add on to that.
No, I think you hit the nail on the head, so to speak. And I think your website also has just the family guide, which kind of is a great synopsis of things that you can, read through or discuss with your daughter. And I would just add, the more upfront you are, the less of a big deal or the less fear that will come from the diagnosis. Syndrome is such a scary word. A lot of people say, oh, something's seriously wrong. But the more upfront you are with her, and the more she knows about it, the less fear she's going to have.
Yeah, that's a great point. And that's the advice we also give to people. And again, yeah, our website has so many different types of resources. And another resource we do have on our website is just tips for every age for administering growth hormone with your child. So just some simple tips like with the younger kids, allowing them to hold or squeeze a teddy bear or have playtime afterwards, like rewarding them for being so brave. And then as they get older, helping them get more involved in the process of taking the injection, like you mentioned, Dr. Roper, and having conversations. So there's a lot of tips on our website specifically related to growth hormone, if you just want to check all that out. And yeah, so we'll move on to the next question. With the average height, the average height without growth hormone is 4'8". Is there an average height with growth hormone?
That is a good question. Actually, actually without or with growth hormone, I would have to say that's really hard to say. Maybe 5'2"-ish. Somewhere around the low fives. For a normal female in the U.S., the average height is 5'4". Actually, for a normal American adult female, it's 5'4". So depending on mom's height again and dad's height and that calculation that I mentioned, that's where you're going to get kind of your goal and expected, where she would have been without it and how close she's going to get with it. So that's a little bit of a difficult question to ask, with growth hormone. But I can tell you that over 90% are reaching above 5 feet with growth hormone now, if it's administered and started appropriately.
Great, thank you. So let's see, we kind of just talked about this. They said, I'm interested in reference material to help my 6-year-old granddaughter understand Turner syndrome and growth hormone at her maturity level. So we kind of just answered that question. We talked about the Tina Talks Turners and the other resources on our website. Anything else you want to add there, or we can move on, Dr. Roper?
No, I think you got it.
Okay, great. Okay, so we do have a couple questions about reproduction possibilities. So I'll kind of read both of them together. So one person said, how or when do you evaluate reproduction possibilities? And again, this is like a whole other webinar, so we could definitely do that, but maybe you could just touch on it. And then someone else said, we've never talked about the possibility of infertility, and this person's daughter is 12. Is this discussion coming up very soon? So I think they're kind of the same question.
Yeah, they are. And just like short stature, infertility is seen in over 90% of those with Turner syndrome. I would say maybe 99%. So it is a big deal, and it is a big and scary discussion for a mother. I can only imagine. I think that at 12, I think it's a perfect time. I think any time that she is asking about, babies, I'm going to be a mother, it's a good time to kind of have it. And the way my mom kind of phrased it to me is, this is how a normal baby is made. You can be a mother. You may not be a mother in the normal way that everybody else that you see, but you can be a mother by adoption. You can be a mother through fertility treatments. There are other ways to be a mother. And as far as how to tell or how to test for infertility, so to speak, I think was a part of the question. There are 2 hormonal labs, specifically FSH and LH. These are your sex hormones that your pediatric endocrinologist can test for. And if they are in the menopausal range, then you know that there is ovarian failure. If they are not in the menopausal range, then ovarian failure has not occurred yet, but most likely it will occur by the 20s, in again about 98, 99%. But that is a good way. You can ask for those labs to be done. Usually as a preteen, we kind of do them at the preteen age, because you're really before 10, 11, 12. There's really nothing you're going to treat. There's really, you're not going to start estrogen therapy before then for ovarian failure. So unless you really want to know, then there's really no need to get those labs before kind of the preteen years. But if you do want to request an ultrasound and those hormonal labs, you absolutely can do that.
Great, thank you. And we did have another webinar, I guess it was last summer. So it's about a year ago, but I think most of the information should still be very relevant and accurate. And it was fertility options for those who have Turner syndrome. And the presenter did discuss having those early conversations about infertility, early family planning, and just kind of thinking about the future opportunities and future options. So if you're interested in the follow-up email, I will send the link to view the recording of this webinar, but on the same page, you can see all the past webinar recordings. So go ahead and view that. I think it was called Fertility Preservation in Females Who Have Turner Syndrome, but it's on that list, so that might help answer some of your questions as well. But that was a really great response. One more question, and this would be like the final call for any more questions, but we do have one currently. Someone said, Cora was diagnosed with Hashimoto's thyroiditis. It's a tongue twister. She also has experienced a slight curve in her spine. Have you heard of Schroth therapy and its benefits? We started and it seems like great support.
Okay, how about, what is the therapy?
Schroth, Schroth.
I have not heard of that, unless unless she's referring to like a bone lengthening type therapy. That might be what that is, if I'm understanding that correctly. But that is not recommended. If that is what it is, that's not recommended in Turner syndrome, just because it's actually a very painful procedure and really unnecessary when you can get good growth with growth hormone and the combination of growth hormone and estrogen. But no, I haven't really heard of that, if that's not the therapy that I referred to. Yeah.
Okay. She just said her orthopedist recommended it. It's all about strengthening her core and awareness of posture. So, Christine, maybe there's like, you could reach out to us if you would like, a second opinion or more information. We could, connect you with someone to have that conversation with you. But some of these things we might not be able to, address right now, just because it's all very specific to different situations. So we're always available. If you call us, if you send us an email, we can answer questions or try to put you in touch with someone who could give, some more information about those specific things. So one person did just add a question: can growth hormones help with bedwetting?
Oh, that's a good question that I've never been asked before. Actually, not to my knowledge. They are two separate issues. I'm not sure. There are many reasons that a girl can be bedwetting, and that's something to discuss with your pediatrician. But as far as growth hormone helping it stop or causing it, there's no relation that I'm aware of. Unless, of course, the bedwetting started after growth hormone, then you'd want to get the blood sugar checked and make sure there was no diabetes or glucose intolerance. Other than that, it would have no relation. And if I can comment on that question before, for scoliosis, during or without growth hormone therapy, your pediatric orthopedist is a great resource because there are several physical therapy exercises that can be done. There's several braces that can be considered to help with that. So they are the absolute great resource for that.
Okay, great. And it sounds like this is another topic for a webinar. So this is awesome. We get more and more ideas the more we talk to people, and we really want to continue doing this program because there's just so many facets of life with Turner syndrome, and we want to make sure to address all the topics so that you have the chance to get in this live session and ask questions and just learn. So we really appreciate you all joining us for this session and asking such great questions. And we will be putting a feedback survey up on the screen. If you wouldn't mind just answering 5 quick questions, just to tell us what you thought about the presentation, that would be really appreciated, so we can make sure we're doing a great job and we can continue to improve in the future. And if there are any questions that come up after the session ends, I did put all of our contact information in the chat box, our website, our general email, and our office phone number. So you can feel free to reach out to us and we can try to answer any further questions you might have after the session. But the feedback survey is up on the screen right now. And I think that concludes our session for tonight. And I just want to thank you again, Dr. Roper, so much for preparing this presentation, giving your time and expertise and answering those questions. And we really look forward to working with you again in the future. And if you have any final thoughts, go ahead.
Absolutely. Thank you, Liz. And it was a pleasure to talk tonight. And I hope I've answered some questions and again, kind of allayed some fears about growth hormone. It can be a scary subject to broach, but the more you learn, it's actually not that scary.
Absolutely.
Our goal tonight.
Definitely. We'll continue having these conversations, keep this conversation going. One other thing I will tell you all about while we're here is we do have the Star Sisters online Facebook group. And if you join it through our website, you can join the Facebook group. It's a private group that you have to almost apply for. You kind of just sign up on our website. That way we everybody and make sure it's really a safe space for Turner syndrome patients and caregivers. And that's a great place if in the future you have questions just for peers. You can, put your questions in the Facebook group, and then people can, it's more of a peer-to-peer conversation about Turner syndrome. It's a great phone or just learning what other people's experience has been and things like that. So definitely check out Star Sisters and our future webinars, resources to access. So we hope you'll all stay connected with us and look out for the follow-up email from us tomorrow. So thank you so much, and we all and are safe and healthy and well. Okay, so bye, Dr. Roper, and bye, everybody.
Bye. Good night.
Good night, everybody.